Wow, that was fantastic. I always am amazed at how small and mighty we are as a School of Public Health, and I think you've just seen an example of just how mighty we are with all of the presentations. So we're transitioning now to our Q&A session, and we're going to invite all of our faculty presenters, I believe students as well. We have enough chairs for the students, or no? All right, we'll see. Hopefully we'll try to make that happen. And then also we want to collect any note cards with questions on it. We'll also sort of pass a mic around as well if you have your own questions that you weren't able to write out on the note cards. But we'll start with the note cards first. Okay, so I am going to start it off with a question for Professor Brenda Eskenazi. And this question states, how are public health researchers able to identify the direct links between environmental exposures and health outcomes without conducting lab experiments? Are claims of impacts of exposures based solely on statistical correlations?
So partly the answer to that question is we need it all. So we need the molecular biologists, we need the laboratory scientists, and we need the epidemiologists. And we need to look at the weight of the evidence of all three disciplines or multiple disciplines to be able to determine if an environmental chemical affects human health. In our work in epidemiology, we also collect biosamples so that we can actually measure the exposures in human material and correlate it. We use some of the models that Mark Vanderline spoke about to be able to make some causal inference, and I think Mark can speak to how successful that is and how confident we feel about it. But I think that what we really need to say is that it really takes a multidisciplinary approach to be able to establish causality. And it takes a lot of money.
Which you've been very successful at getting, as well as everyone else on the stage. Small and mighty, again, I remind you. Okay, that was great. Mark, do you want to follow up at all with any of the comment about the statistical correlation part of the question and
sure.
How methods have been used?
Yes, I think the advances we talked about are very important for this purpose. You're trying to learn a causal effect of something like an exposure on an outcome, but there are many other factors which are varying. We call them confounders. And if you use kind of simplistic approaches, you easily end up finding signals which are only inspired by the misspecification of your model. So it takes a lot of advanced machine learning to get these answers. And I do think we are getting close to actually getting reliable answers on these, but at the end, there's a lot of uncertainty in these data sets. They're not always large enough, so at the end, the confidence intervals might still not be conclusive, and that's just part of statistics. But by no means, the statistics has to be sound, but indeed, we need a lot of science behind it. And so I think there's just statistics is certainly not going to solve the problem.
Great. Okay, the next question is speaking to several presentations that mentioned or focused on the disproportionate burden of health in Hispanic and Latino communities, both within the United States and globally. And the question is, would you care to comment on the current difficulties in studying these populations in the presence of the current political climate within the United States? And so we have both faculty and students who can speak to that, both in terms of the importance of using community participatory research to really engage effectively with these communities, but also understanding their unique challenges and concerns given the current political climate, and then as well as some of the strategies that you've employed in the research that you've been doing.
I hate to dominate this, but I've been following a cohort of 600 families living in the Salinas Valley for the last 20 years. And we never asked about documentation status, but we assumed that about 75% of the families, at least one parent was undocumented and still remains undocumented. We don't want to know that information. as someone who's really a reproductive toxicologist, about a year ago, actually the week after the election, I switched courses and said that I really need to look at how the fear of deportation in these families is affecting the development of these kids and of the family system. And so we have already published a paper showing how deportation fear is related to blood pressure in the mothers, and we are about to publish a paper on how it's also related to the health of the children, who, by the way, are U.S. citizens. So this is a very unfortunate situation. Fortunately, our cohort really trusts us, so we haven't lost them. But there are days that we can't interview because INS is out, and so we have to be careful about what we do. So it is a very difficult time in our cohort.
I would say that research I've done in the safety net, which I didn't present today, really shows that the two most important factors that explain disparities in healthcare quality for Latinos and non-Latinos are having health insurance and a usual source of care. And that explains most of the disparities. And I think with the political climate, it's really hard to achieve both of those things. We've done some public opinion polling around the state of California to look at the voters' attitudes towards expansion of healthcare coverage for the undocumented. The Latino community, clearly voters, residents who are eligible to vote, are very enthusiastic and supportive of this. However, fewer than 50% of non-Latinos support insurance expansion for the undocumented adults. So politically, we're facing a huge challenge with public support. And I think it's largely from the rhetoric that's happening at the federal level with respect to who's deserving and who's not deserving of health care.
Catherine, did you want to say anything in addition?
I was just going to say briefly that one of the many topics that youth researchers have studied in these projects relates to the experience of undocumented students and sort of how the schools can better support the students. And so there, as we've seen on campus and around the country, there are many brave young people who are really sort of openly advocating for themselves. And so, I think there's some ways in which they've been able to use these approaches to help inform the systems to sort of help support.
In terms of childhood leukemia research, we had been working with the local hospitals, and again, I think at that time it was the pre-era of the current climate. I think we were really successful to enroll Latino families, and thanks to the clinicians who were helping us with that. Now we're kind of moving towards prevention and trying to reach out this community to alert them about potential risk. And we're fortunate to work with promotores. Those are health educators, and they're pretty well organized, and we really feel fortunate that we can use their momentum, and I don't think they are going to stop to work locally and help the community. So those people are really great resources, and what I describe in terms of exposure to chemicals that lead to childhood leukemia, the same chemicals are actually leading to other serious health outcome in children. So we are kind of rallying forces and not just talking about childhood leukemia, but talking about the exposures and many different diseases in children. So we're really working with the promotores here locally, and we are also working with groups in Latin America, in Mexico, in Costa Rica, and likely, they don't have the same issues, and we can, send the message across through Latin America countries as well.
So our work focuses mostly on increasing colorectal cancer screening rates in the Latino community, because there is a disparity in screening rates. And for us, trust is a huge part of community-based participatory research. And because we've been working with this church community for the last 5 years, we've been able to build trust by just showing up, even when we're not asking or needing things to happen. And part of why we chose our intervention to happen in the church is to actually go to where the Latinos were. So as Hector mentioned, even though Latinos may have access to health insurance, they may not be navigating it, and we needed to find a way to get to them. So, thank you.
Okay, this next question is for Hector and Steve. And the question is, and comment, it was surprising that when health systems had better coordination to improve patient activation, it didn't result in better health outcomes. And do you have any insight into why not and next steps in thinking that through more?
So we didn't present a lot of this, but what Mahasin's referring to, we didn't see that practices that were doing more actually to engage their patients, actually their patients weren't having better outcomes of care, and we also found that they didn't have better clinical outcomes like control of their diabetes, LDL, et cetera. And I think it has to do with that diabetes and cardiovascular disease are oftentimes silent diseases where people can feel fine and have good social functioning but have really out of whack clinical indicators. I think it underscores the importance of treating patient-reported measures and clinical outcomes distinctly. What we learned from our practice informants that there's this huge pressure among healthcare systems to check off boxes that they're providing appropriate care, and it really misses the boat on these social determinants of health, depression, and these other factors that play more into diabetes control than what the health system focuses on. So I think the fact that it's a silent, diabetes and cardiovascular disease are often silent and asymptomatic, this linkage between activating patients and the resulting impact on their clinical outcomes and patient-reported outcomes is loose.
Yeah, I would just add to what Hector has said that in some of the interviews we alluded to, we had people to tell us in the fact that there was such pressure on them to hit certain targets from the health system and so on. They didn't have time to really spend with the patients or their family. And part of that, of course, is it doesn't have to all follow on the primary care physician, right? It's a team-based approach that's really needed in our healthcare system now. And we saw a great deal of variability in the extent to which some of the primary care physicians knew how to delegate to the team, to make use of the social worker, the nurse, and so on. And in a couple cases, I remember it was actually the receptionist who had the most contact and understood the patient, that may have been a neighbor and so forth, that was a key communicator actually on follow-up for various regimens of care. So it's going to take time for some of this. And one way, a framework to think about, I mean, you read about it all the time in the papers and that, to think about what's going on in health policy in this country around these issues is incentives on the one hand and the ability and capabilities to respond to those incentives on the other hand. And we need both. We need to change payment, clearly, to go away from this fee-for-service and create incentives to keep people well. Think Kaiser Permanente, but that's only one example of that. But on the other hand, you need the capabilities of the provider community and we as patients to respond to those incentives. And that's going to take time, but there are some encouraging signs as well.
So several of you will be able to speak to this because as faculty, we have very diverse research funding portfolios. But nonetheless, this question is, how does academic public health research keep up with industry? So this is sort of Facebook, 23andMe, and sort of other examples where they have more money, access to big data, and it's less driven by current politics. So how, as academics, are we able to keep up with all of that?
So I think we don't keep up, we're actually ahead because we have the energy and the know-how of the students and our collaborations here within this institution. So I think industry really looks at us for, and tries to keep up with us and our innovations, not the other way around.
Just a quick comment, because some of the companies mentioned focus on technology or media, et cetera, is just to say that I think there have been some exciting or sort of interesting partnerships around using new technologies for health. Obviously, the whole mHealth movement. I think one of the things that I think we see at the university is that sometimes a lot of those solutions are very technology driven. So it's sort of like, well, instead of talking with your doctor, you'll get a text, or trying to sort of take what were other kinds of interactions or other kind of health promotion or behavior change type efforts and putting them and using technology for them. And we know that there's a lot of powerful potential there, and for those of us who work with adolescents or who have adolescents, or we know that how much say technology has transformed lives and connections and development in a lot of different ways. I think the challenge for the partnerships between some of these companies who are either technology companies or gathering lots of big data, I mean, some of the challenges, how do we do this work in ways that are theory driven? And not having the tech, just because it's technology, thinking it's going to work, but realize that there are a lot we've learned about health and health promotion, and that needs to relate. And of course, obviously, there are huge privacy and ethical issues that have to do with big data and who gets access to it and how do communities get access to their data. So I think there's a very interesting space around I think there's interesting work to be done about sort of where partnerships between a university like Berkeley and some of these big companies can go.
I'd like maybe to take another angle in terms of childhood leukemia. I think most of the eyes are actually turned right now to treatments. And I think it's, you can understand, you have your child who has the disease, and most of the focus is to treat the child. And most of the money from NIH has been, driven by the treatments. And I think that most of those new technology in terms of, companies out there are really working on the treatment side. I think this is, when you understand that at individual level, I think at the population level, it does not make complete sense to kind of really focus the money completely towards that. The margin benefit of any increase in treatment will be pretty small, possibly. I think a big lack is in prevention. And I think that we know enough to start really doing some work in terms of prevention that doesn't require high-tech level, that requires come back to the basics, come and talk to people, come and talk to the communities, and they can understand very, very easy messages to reduce exposures. And even if the link is loose in terms of causality, it's not going to hurt. But I think people are kind of losing this, go back to the basics, we know a lot, can we do something by talking to people? So I like to make sure people understand there's a big gap in terms of where the money is going, in terms of genetically oriented research versus prevention and change of behaviors. And this is what we've been really struggling with in terms of getting funding from NIH with just a little drop in the big buckets.
Mark, I was wondering also if you wanted to comment at all about how big data is not just outside of academia and how we're able to sort of use big data as well as causal inference methodology to sort of improve population health. So that part of it.
Yeah, it's a very exciting time with the immense, essentially everywhere people are building databases, capturing whole populations. And so this gives a unique opportunity to really get to the bottom of all kinds of interesting questions. And so, for example, in safety analysis is one thing where they're building a 300 million patient database, which can be analyzed for the purpose of figuring out what are the signals, which drugs are causing some safety issues, and so on. There's also a lot of opportunity for individualized treatment, so learning from data, what are the optimal individualized rules for treating a patient. I think these are all, the current statistical tools are not made for that, but the kind of tools we talked about are exactly able to do that. And so I think there are immense opportunities there. Yeah, regarding the industry, in some ways I see them doing things we should be doing in medicine and public health. For example, like I talked about the adaptive designs, right, where you learn from the past trials and adapt your randomization of your treatment or intervention for the next group based on what you have learned. That is happening in industry, except they do it, of course, in things like Facebook and Google. It's just a little easier to do it there, but they are actually jumping on all these advanced approaches, while in medicine, FDA, it goes much slower. So in these ways they're ahead. I also see in many ways they really suck up the expertise we have. I mean, I see they always jump on students, and that's their way to suck everything out of you. So they get a good deal, I must say. But I think it goes both ways.
Yeah. Just to add briefly to what Mark has said, on the delivery side, more and more of these large integrated healthcare systems have large databases now they've amassed over years. So Kaiser Permanente, obviously, but the Mayo Clinic, Intermountain, Geisinger, there's a bunch of these now that provide real opportunities to look at, to use some of the super learning techniques, roles for our graduate students to embed their research into the delivery system as well. And so this is something that has not existed, say, 10, 15 years ago, except in the Kaisers. So on our own faculty, for example, I don't know if she's here today, Lisa Barcelos has done a lot of genetic epi work using the Kaiser databases. They have data on hundreds of thousands of patients over time, 10, 15, 20 years. And so this is going to be a new phenomenon I think we can learn from as well.
Maybe just quickly to speak to the genetic technologies that we work with. We have funders who would tend to favor private companies to work on these problems, but there's a certain niche where there isn't a business model for these technologies. So if we're developing the technologies that can control disease on a wide scale, which is really exciting, then that's not something that can be sold as a product so easily, but it is something that's very well suited to research at higher education institutions.
So I'd like to talk about the downside. We've all talked about the fact that big data will become available, that if we partner, we'll have innovative technology. But in my field of toxicology, of environmental toxicology, it's dangerous for us to partner with industry because their goals are economic, to produce more chemicals, that we don't know necessarily, but they might know whether they're poisons to human bodies. And so right now, with EPA money getting smaller and smaller, there's going to be a push to create those partnerships with chemical companies that are very, very dangerous. And so there is an upside for some fields, but there's a downside for other fields within public health.
Great. Thank you. So now I just want to address this particular question. I mentioned earlier that you'll hear examples of how the social determinants of health are embedded in the work that we do. It's part of our mission as a school, and we're a real leader in that area. But given that the presentations were short, there was a question about exactly how we're measuring social determinants of health within various projects. So as an example, this question, which was directed at Hector and Steve, had questions about whether health literacy was examined, whether or not education level was examined as part of the work that you're doing, or how we're missing individuals who don't have access to care as part of that work. But maybe others as well could speak to the ways in which they're incorporating social determinants in the work they're doing.
Do you want to?
Yeah, so we did measure education and actually control for that in our models. And so that's accounted for. Health literacy is a tricky thing and how to measure it. And so we didn't go down that route. So that is potentially a confounder. I would also say that in this population of diabetes and cardiovascular disease, especially among older adults, social isolation in particular, not being divorced or not having a partner, living alone, is a major risk factor that we didn't consider necessarily. We considered marital status, but we couldn't really tell about the household dynamics. So that's clearly there. In terms of assessing social determinants, this is a huge question, and as researchers, we like to develop all these different batteries and trying to assess them. But in clinical practice and in community interventions, they need short, actionable, well-validated measures. And so there's national initiatives trying to develop standards in this regard that can be embedded in the electronic health record and be used by practices. And so EPIC, one of the largest electronic health record system, now has a module on assessing the social determinants of health. think one of the challenges that we have in clinical practice too is that we don't have a lot of guidelines about the periodicity of which these assessments should be made, and should we do them all at once and burden the patient and to do a 20-item, 20 different batteries of questions. So I think these pragmatic issues about how do we actually routinize the assessments of social determinants and social risks among patients is a huge issue that we'll have to overcome to address these things. The ACOs that we worked with, the health systems, were largely commercial insurance. They do have some Medicaid populations there, but they aren't in uninsured populations. I would imagine some of the relationships that we looked at are different in underserved populations. I did a study looking at patient activation in health center patients, mostly Latino and obese patients. And we found actually no relationship between being activated and actually self-reported physical activity or other behaviors, which makes me think that that measure may not work the same in really low income populations. So
We did, just to add quickly, we did look at English speaking versus not, and in one of the ACOs we did have a fair percentage of Hispanic patients, so we did look at them as a subgroup as well, and relationships were reported basically held there. There's an interesting work going on in the UK and elsewhere developing the deprivation index, and as Hector has said, if we can get something like that into the electronic health record, and some of the work that's being done on the part of the National Academy of Medicine, Nancy Adler and colleagues at UCSF have helped in this regard to get these kinds of measures routinely into the database so we can begin to take these into account.
Okay, I'm going to just conclude with one final question. And as you saw in the presentations, our doctoral students here at UC Berkeley are very impressive. It's part of why we get to shine as faculty. And I couldn't distinguish their presentations from the faculty presentations. They were really spectacular. And so this question is directed to them. In your view, what's special about being a doctoral student here rather than somewhere else?
Well, I'll take the initial stab at it. I think part of what's exciting about being a graduate student here is that the faculty actively encourage us to go beyond what we initially came here for. So I initially came here looking to do waterborne diseases, and while that initial project didn't work out, the faculty members that I encountered in my department said, you are the kind of person that asks why. You're not satisfied by simply doing a simple analysis and calling it quits. You really want to understand what's going on underneath the hood. Maybe it would be worth your while to go into biostatistics and further your understanding of what these models are doing, how the math underlying all of these tools actually works. And that led me down a road, a very painful statistical road, where I did pursue sort of advanced coursework in the biostatistics department, and I'm a much better sort of young scientist because of it. I still have a long way to go, but I don't think that would have happened at other institutions, and I'm incredibly thankful that the faculty here are not just supportive, but they're looking out for our long-term interests.
Yeah, I'd just like to follow up with that. When I arrived here, I was leaving a job in industry managing databases at a hospital, which was very comfortable but not very fulfilling. And I started working with Dr. John Marshall, and I originally I did my master's in epidemiology and biostatistics, my MPH under him, and I had no intention of continuing to a PhD, but he kept nudging me towards that path, and one weekend I figured I might as well write the Berkeley PhD app in between homework for classes. So I did that and then got here, and well, I remained here rather. And then from there, met other faculty, including Lisa Barcelos, who is another professor in epidemiology, who encouraged me to pursue the computational biology emphasis, where I met an even more broad array of faculty. So it's really their encouragement that helped me along. And being at Berkeley, as opposed to somewhere like UCSF, I've had the chance to take classes in statistics, computer science, computational biology, and of course in public health. So it's been a really gratifying experience.
For me, again, also I'm going to echo faculty. I've had some of the most incredible mentors being here. Dr. Amani Nurajiter has really helped to foster the kind of scholar, not being a data-driven scholar, but actually to be a scholar that asks multifaceted questions. Working with Dr. Emily Ozer has also kind of advanced my thinking around community-based participatory research. And the mentoring that I have received here, it's not just about me, it's also how I have been able to mentor others. I have an incredible research team. My research project coordinator is here, Nazanin Kandahari, who is accepted into the JMP program. And initially, even though I was asked, I came here because I wanted to run a cancer center. And in the 5 years that I've been here, I didn't think that teaching was something that I wanted to do, but I fell in love with this life, this discipline, this research that I do, and I've just accepted a position at San Jose State University as a tenure track professor. So, thank you. I don't think that would have been possible without me coming to UC Berkeley, so I'm very, very thankful.
Well, great. We are out of time now, and so I would like to welcome you in joining me to thank our wonderful panelists, our faculty, and our students who gave fabulous research presentations. I would also like to thank those who are live streaming with us right now, and hopefully you were just as blown away as we were in the room here listening. And then I want to thank all of you in the room as well, and to again thank you for joining us for our wonderful celebration this weekend. We hope to see you more at the remaining events, and we're going to have a couple of minutes here where the faculty will be around as well as the students to answer any of your additional questions. So thank you all, and enjoy the rest of this lovely, wonderful, sunny day here at Cal for Cal Day, and go Bears. Thank you.